मैम अभी उनका सीटीएनजी हो गया, अभी सुमित सर से मैंने बात की है, उनको भेजा है, पेशेंट का ना नंबर भेजा है, फिर वो सीटीएनजी रिव्यू करके बताएंगे मैम।
हो गया। ये
ये
मेरा। हाँ, आपका।
आंसर करना। We'll be starting in another 2 minutes.
Hi everyone, am I audible?
Yes, sir, you're audible.
Sorry for something. I just okay.
Good evening, everyone. Welcome to Mahamana Case Discussion Series. This is our fourth year of Mahamana Case Discussion Series. And today we have with us Dr. Harsh Dhar. He is a senior clinic oncologist from Manipal Hospital, Kolkata. And he's going to give a talk on Salivary Gland Neoplasm, Controversies and Changing Paradigm. Welcome, sir.
Hi, thank you. I will just share screen. First of all, a big thank you for the entire team at Mahamana for this very gracious invitation and opportunity to read up as well, because obviously this is a very important topic and something that is quite hot off the press. So much of literature going into it. I would once again want to congratulate the entire team at Mahamana for continuing this wonderful series of classes and lectures. It's always a pleasure to listen in on Thursday evenings, and I think many of the residents, fellows, trainees, and even many of us who are beyond the official training period are really getting benefited by it. With that, I would just go ahead with the presentation. Salivary gland neoplasms, controversies and changing paradigm. Well, a disclaimer, I've tried to focus more on the diagnostics. I've tried to focus more on the ancillary tools that are available, the focus towards more core biopsies, and of course, something on surgery, though our surgical principles are still quite the same. And of course, the importance of targeted therapy. There are some things which I have not stressed too much on. That is adjuvant therapy. Of large, we'll just touch upon them. Yeah. So the existing scenario for salivary gland cancers is that management has been limited and constrained by anatomical and histopathological complexity. These are very rare malignancies, and biopsy traditionally was contraindicated for these tumors with a greater dependency on FNACs. However, the last 2 decades have showed us that FNACs are now becoming a hindrance to accurately diagnose or distinguish the particular subtype. Because, as you know, the WHO has come up with 30 different salivary gland cancer subtypes, and many a times FNAC is not adequate to give us the proper subtype, and more so to run molecular diagnostics on them. Standard treatment paradigm that exists today is the surgery first approach, which is managed by a complete surgical excision and margin control with adjuvant RT being conventional format. Systemic options that we have are mainly for the recurrent metastatic setting and are largely restricted to our empirical and cytotoxic chemotherapy regimens with low and transient response rates. Now, the path ahead that the body of literature over the last 2 or 3 decades has paved for us has shown a significant transition or promotes a significant transition towards core needle biopsies. Many centers have already moved towards it. Many centers are in the process of judiciously using core biopsies for select cases, which again is quite correct. And many centers have absolutely moved away from FNACs and just to FNA biopsies. Of course, this helps in two ways. It helps for diagnostic reclassification of misdiagnosed tumors. It also helps in providing us targeted or precision systemic treatment wherever applicable, especially in the locally advanced recurrent or metastatic setting. Now, more conservative surgery has been adopted, especially for pleomorphic adenomas and also for select other malignant cases. There has been a lot of integration of advanced particle beam radiotherapy, and that has modified local management of the historically radio-resistant salivary gland cancers, most notably the adenoid cystic cancers. Now, traditionally, FNAC has been our go-to tool, and we have this famous meta-analysis by Schmidt, which showed that FNAC was better for differentiation between neoplastic versus non-neoplastic lesions. However, not so reliable, less reliable for differentiating the benign from the malignant lesions. And if you look at this funnel, right, if you look at this funnel, this shows that although it has a very high specificity to filter out the non-tumor cases, it has a high false negative false negative rate, which can be even as high as 50% of true malignancies, might slip through the net of FNACs and get diagnosed only on final histopathology. So this is definitely a lacuna or a fallacy of fine needle aspiration cytology. And we now have a lot of evidence to show that definitely core-needle biopsy is a safe modality with high sensitivity and specificity for the malignancies, 96% and 100%. It also has a very high concordance rate with histopathology, and it is a safe procedure with this large systematic review, 512 procedures showing no report of tumor seedling. Now, when do we go for a core needle biopsy? Normally in cases or in centers where FNAC is the go-to, when repeated FNACs are inconclusive, but a strong suspicion for malignancy exists, where tumors have more than one lineage, for example, myoepithelial carcinomas, or even with suspected lymphomas. And of course, frankly inoperable tumors where biopsy can aid in the analysis of gene translocations or mutations and which can be used for any therapeutic implications. Now, another fourth entity exists, and today we are going to talk a little bit more about it because with larger tumors, especially there is evidence that with tumors more than 4 centimeters in size, there obviously is going to be a lot of cystic degeneration, a lot of necrosis, and hence your fine needle aspiration sampling may not always yield proper tissue. So as tumor grows larger, the the chances of your FNAC missing the target is much higher, and thus, in these cases, they should be ideally subjected to a true cut biopsy or a core needle biopsy. If you compare FNAC, core needle biopsy, and intraoperative frozen section, just moving this here. Sorry. Yeah. How can I reduce this?
What do you want to reduce?
This bar at the top.
Okay.
Okay, one second. एक minute.
I'll only have to do it.
I think
It's okay. Yeah, just let it. Yeah. So if we compare FNAC, core needle biopsy, and intraoperative frozen section,
Is this okay?
it's still the same for me.
Okay.
No worries. Let it. Yeah. So if you look at it, the sensitivity and specificity of core needle biopsy are high. It definitely scores over FNAC in terms of sensitivity. We know that on an FNAC, if the report is malignant, more likely it will be malignant. Whereas on an FNAC, if the report is benign or negative, doesn't always mean that it will be so. That is the fallacy of FNAC that the core needle biopsy has been able to overcome. And if you look at intraoperative frozen section, again, the core needle biopsy somewhere scores over it. So in all aspects, diagnostic accuracy, architecture preservation, and molecular testing utility is scores higher than FNACs and frozen section also. Many pathologists, contrary to belief, are not very comfortable with doing frozen sections because of loss of architecture, loss of important tissue. Now, having said that, it is also important for us to go towards immunohistochemistry because what may look like serous or mucinous or acinar on a normal histopath can be anything ranging from an acidic cell CA to a pleomorphic adenoma to a mucoepidoid carcinoma, depending upon the immunohistochemistry pattern. Now, this is the multicellular origin of salivary gland tumors that we grew up studying. Basically, the four sources of the cells, the acinus, the intercalated duct, striated duct, and excretory duct. Today's theory, what we have is two cellular compartments. The luminal cells, again, the luminal cells, the acinus and the intercalated duct. The luminal cells with their key markers, that is cytokeratin EMA, and the abluminal cells, that is those within the ductal, that is the myoepithelial and the basal cells. So depending upon where your tumor is arising from, the tumor will demonstrate its own classical pattern of IHC signature, and this is very, very helpful in defining or subtyping what tumor you are dealing with. Of course, today with immunohistochemistry signature, we also have translocations, although many centers this may not be available, but this is definitely something on the horizon. Very quickly, an important factor to look at, important markers to look at for actinic cell carcinomas to differentiate between adenoid cystic or mucoepidermoid, we have something known as the DOG1. So many a times this becomes a very important toolkit that is missed in many immunohistochemistry panels, and inclusion of DOG1 has been shown to improve your diagnostic ability in differentiating actinic from mucoepidermoid and adenoid cystic in a tumor where morphology is misleading. Now, IHC profiling, again, the same thing, but one must also remember that pleomorphic adenomas also may sometimes mimic tumors. You have something known as the PLAG1, which can be exclusively specific to PMA and critical for ruling out malignancies. Translocations, a few common there are many translocations which are there in literature. We'll just look at the three common ones from mucoepidermoid CAs. It is the CRTC1 mammal 2. Prevalence is about 40 to 80%. It's highly diagnostic for MECs, and these are often associated with younger patients and decreased recurrence rates. Adenoid cystic carcinomas, it's a MIB activation, prevalence being about 80%, and it is diagnostic regardless of whatever the specific fusion type. And of course, as we said, in the pleomorphic adenomas, you have PLAG1 fusions with a prevalence of more than 50%. The basic concept of a fusion oncogene, and this is for our students, is that you have chromosomes, two chromosomes which align near to each other, and then there are chromosome breaks. Once you have chromosome breaks, you have interlinking of the DNA strands, DNA RNA strands, and at the fusion areas, you might have some epigenetic mechanism going on which can activate a particular oncogene, and thus driver mutation happens and transcription, so on and so forth. So the modern diagnostic paradigm is that if you have a salivary gland mass, a parotid mass presenting to you, definitely USG guided FNAC. But if you're suspecting a high grade pathology, if you're suspecting if it's evidently a very large tumor, it's an inoperable tumor, or if it is a tumor which has been FNAC'd multiple times and you do not have adequate histology, then core biopsy should be the next step. And of course, added to that, immunohistochemistry, fusion translocations, and NGS. Now, there are multiple guidelines in literature available. You have the UK guidelines, you have the HNS series, you have the TMH evidence-based management series, we have the NCG guidelines, we have the ASCO, and of course the ESMO as well. And majority of them, more or less, the recommendations are same. There are some changes in the last few years. We'll just talk about them. The importance of talking about so much for biopsies and going for coronal biopsies and the entire gamut of molecular arrays, because today we have 30 different histologies within salivary gland, and it is very difficult for any even a very experienced pathologist to always give us the right answer. What we can look at, what we can get on FNAC is a grading system, very much like the Bethesda for thyroid. We have the Milan system proposed by Bossi et al. And over here, again, as you can see, grade 1 being non-diagnostic, grade 2 non-neoplastic, grade 3 being ATP of undetermined significance, grade 4 again neoplasm, 4A benign, 4B being it's tumor of uncertain malignant potential, and 5 and 6 are more towards malignancy. So each grade has its own range of malignancy percentage, and based upon that, as long as it is 4 and above, surgery is warranted. Suppose it is FNAC, it is a Milan 3 repetitively, then taking the radiology into consideration, one can offer a diagnostic surgery. Guidelines more or less are towards surgery wherever operable. Surgery and neck dissection. We'll go to neck dissection slightly later. And depending upon the presence of high-risk features, adjuvant therapy is applied. Now, adjuvant therapy, the risk factors, these have remained the common risk factors for over 5 decades, right? From 1977, from Austin Gillimandigi's first paper on the indications of adjuvant radiation, there has not been significant change in the indications. Basically, intermediate or high grade, definitely close or positive margins, neural and perineural invasions, lymph node metastasis, lymphatic vascular invasion, T3, T4A tumors. So any T3, T4A high grade tumor will definitely go ahead for adjuvant radiation. And of course, margin status, nodal status is also important. Having said that, within adenoid cystic, I haven't put up the slide, but there is a very big like meta-analysis in JAMA Oncology, which came out a few years back, showing that for adenoid cystic carcinomas, if you classify the tumors based upon free margins, closed margins, and positive margins, adverse recurrence rates or higher recurrence rates are only with positive margins. There was actually no significant difference seen between free margins and closed margins. So as long as you have a negative margin for adenoid cystic cancers, surgery is acceptable. Surgery is the primary modality of treatment for all the salivary gland cancers, if it is operable. And the extent of surgery, as we discussed, is dictated by histology, grade, as well as T-stage. Now, for benign lesions, of course, a partial excision, that is a superficial gland excision, and nowadays, we even have limited excisions, that is less than a superficial, which could either be adequate paroidectomy and extracapsular dissection. Very important to note in pleomorphic adenomas is there should be no tumor spillage, because when you have tumor spillage, there will be chances of recurrence, and recurrent cases of pleomorphic adenoma, there definitely is a role for adjuvant radiation. Now, these terms of adequate paroidectomy and extracapsular dissection, as we all know, so adequate paroidectomy is, it implies removing the tumor completely, where we are taking a cuff of normal tissue around, and we are also going and identifying the facial trunk, and then just looking at the particular zone where the tumor is, and not dissecting the other branches which are far away from it. Extracapsular dissection, on the other hand, differs from adequate paroidectomy in being that this is, we do not identify the main facial trunk. We go directly on the tumor with magnification and just dissect the nerve ramifications around it. So these two entities are definitely more for benign histologies. And there is a new European classification. I just go to that picture if I have that here. So, yeah. So which lesions are ideal for an extracapsular and which lesions would be for a adequate? So if your tumor is more towards the periphery, wherein you're not going to encounter the main facial trunk or the main branches towards the periphery, then you are safe in not seeing the facial nerve trunk, going right on top of the tumor and working around it. Whereas any tumor which is larger, closer to the branching points, definitely it is a case in point for an adequate paroidectomy, not for an extracapsular dissection. These, of course, are guidelines by the European Salivary Gland Group. This is not something that I am saying. These are guidelines. These are just a reference tool for you to plan your surgery for benign cases. However, for malignancy, it's completely different. Let's just go back. So, sorry. In malignant tumors, as we know, the dictum always is small T1 tumors, low-grade tumors will undergo a superficial gland excision. All rest high-grade T3, T4 tumors will be a total conservative. And why is that? That is because That is because the high grade tumors or the T3, T4 tumors have a higher incidence of having intraglandular lymph node metastasis. And of course, that is why we need to go in for a total conservative. What are our criteria for inoperability? And this definitely again has not changed. Skull base involvement, involvement of pterygoid plates, nasopharynx, carotid sheath, prevertebral, the standard. As I said, sorry, we're going ahead. Yeah. Is there now a role for doing a less than a superficial gland excision in malignant tumors? And that is the question that we asked. Literature is very scarce. This is a review of 3 papers that I encountered. Small volume patients, and all of them, a less than a superficial gland excision was done, and very good outcomes overall. This is a systematic review of 9 papers. However, they conclude that the evidence actually is weak for recommending less extensive procedures than a superficial gland excision. And this is applicable only to unique cases. Suppose a patient has already been operated for an adequate paroidectomy and then he comes to you with a histology of malignancy. And if there is no residual tumor left behind, these patients may be observed. This was the conclusion of this particular systematic review. Now, what do the guidelines say? Let's just have a look at it. So the ASCO guideline clearly says that surgeons may perform partial superficial gland excision for appropriately located superficial T1, T2, low-grade salivary gland cancer. And look, the evidence quality is low. The strength of recommendation again is weak. So we must select our patients well. We must counsel the patients well. Again, that in case the final histology comes out to be high grade, there might be a case in point of adjuvant radiation, wherein we will have to treat the region of the parotid, as well as we might have to electively irradiate the neck. So as of now, this is definitely an important controversy, and we are awaiting more multi-institutional literature for that. Management of the neck. When we were training, there were 2 schools of thought. One is routine level 2 sampling for all cases. The other school of thought was next should be addressed in aggressive histologies, T3, T4 tumors. Which are these aggressive histologies? This again is from the AHNS Know Your series paper. And definitely adenocarcinomas not otherwise specified, carcinoma, expiomorphic adenoma, salivary ductal carcinoma stood out in the percentages of occult nodal metastasis, as we can see over here. Now, this again is a snapshot from ASCO, the ASCO guideline, where they again talk about the histological types with high prevalence. And this more or less mirrors what we just read. This is a meta-analysis by Dr. Manish Mai and 13 publications, 818 patients. Important for you to note that those who CN0 had an incidence of occult metastasis to the tune of 32%, which is very, very high. And taking an extrapolation from the oral cancer debate, any situation where you have an occult total metastasis more than 20%, you must do an elective neck dissection. And in their series over here, in this meta-analysis, they discovered that the incidence of nodal metastasis was actually higher in levels 2 and 3, not so much in levels 1. So what they proposed was, in salivary gland cancers, they did advise doing an elective neck dissection where at least levels 2 to 3, including level 4. So a 2, 3, 4 selective neck dissection was their advice for the occult nodal metastasis. So again, today we have probably a third school of thought wherein we might be looking at centers which are doing routine selective neck dissections even for CN0, given that the burden may be as high as 32%. Now let us go into the different scenarios that might happen as per the ESMO guidelines. And they say that, of course, if it's T1, T2, low risk of occult nodal disease, and this is after resection of the primary, then you can carry out a wait and watch approach. Now, suppose this was diagnosed to be a malignancy after the surgery, you recommend an elective neck irradiation if you've diagnosed PN plus after the surgery has been done and the neck has not been adequately treated. However, if you already know that this is an aggressive histology, then as we just discussed, an END of levels 2, 3, 4 and postoperative neck adjuvant radiation should be offered to these patients. So that is, in a nutshell, how we have now progressed towards the management of the neck. More and more literature suggesting that salivary gland cancers have a higher rate of occult nodal metastasis than what we originally thought to be, and hence it might be safer to offer patients a selective neck dissection level 2, 3, 4 at least. Management of the facial nerve. We'll go briefly through this. So, of course, the role of IONM has been established. If you have it, use it. We will not go too much upon into the debate. There is a definite improvement in the temporary rates of paresis as compared to the permanent. And this is definitely advocated for locally advanced and recurrent tumors. Now, where did the philosophy of facial nerve change? Earlier, the philosophy used to be that wherever the facial nerve, wherever you have a salivary gland cancer, it was advised to resect the facial nerve, to sacrifice the facial nerve rather than preserve it and subject to adjuvant radiation. However, we did see that in patients on whom the facial nerve was preserved and adjuvant treatment was given, there was actually no statistical significance in survival rates. And this particular paper by Izeli and Hoffman actually brought about the change towards facial nerve preservation in salivary gland cancers. This was a laryngoscope study. We will skip this. The factors to consider for facial nerve sacrifice again are preoperative facial nerve function, and the role of intraoperative frozen section is debatable. There is varied literature on it. If you have a reliable pathologist whom you feel can give you a good diagnosis, then no harm in going ahead with it and using the presence or absence of tumor involving the epineurum to guide your decision. Of course, preserving the branches is important, and wherever a plane can be created, one must do meticulous dissection and try to preserve. This is an example of an acinic cell CA where we did encounter a lot of tumor tissue at the bifurcation point. This is the main facial trunk, and this is the superior division. As you can see, we've done a lot of micro dissection around it. It's quite red, but we had to sacrifice the lower division and do a sural graft. When to do a neurography? Definitely at the primary setting if possible. End-to-end neurography can be done. And now we're talking about changing paradigms. There is even from a direct sural cable graft, we now have moved towards vascularized sural grafts, which are being used, wherein the vasa nervorum of the sural nerve is anastomosed to the fine vessels or branches of the superficial temporal artery, thereby leading to more robust take-up. And there are a lot of evidences in literature which supports this. For shortage of time, I've not gone too much into it. Now, role of systemic therapy is something that we are still awaiting. As far as guidelines are concerned, we still do not have any clear-cut guideline advocating the addition of systemic therapy in the adjuvant phase. We are awaiting the results of RTOG 1008. So this is again the recommendation from ESMO, which said that in the setting of patients undergoing adjuvant radiotherapy, addition of concurrent chemo may not be routinely offered outside of clinical trials. So if you are advocating the addition of chemotherapy, it has to be advised to be in a trial setup in patients in whom you feel there is going to be a direct benefit. Now, contrary to what we believe, guidelines do not always support the addition of targeted therapy, even for patients with salivary gland tumors expressing AR and HER2/neu, as long as you've done an adequate resection and the patient has undergone adjuvant radiation. Although Many centers do follow this practice. This has still not found its way into the guidelines. Uh, Precision oncology in salivary gland cancers is something that is has evolved. It is still evolving. I don't think in India we have too many centers which can actually afford this kind of treatment, but it's important to know. And I've just given the example of salivary duct carcinoma here, which is an important take home, and it mirrors a lot with the breast cancer, wherein even in salivary duct cancers, which manifest AR positive, it is seen in 86 to 98% of cases. There is definitely a role uh, in administering androgen receptor antagonists. And what literature shows is that even after administering, the response rates are not too high, right? And the median progression-free survival is around 8 months. Overall response rates would be somewhere between 45% to 65%. Uh, Partial or complete response rate seen in 42%. And what definitely happens is there is a lot of resistance that happens towards the later part of the therapy. And that again is an important factor to look out for. So whatever significant data that we have at present is in this particular entity of salivary ductal carcinomas, but that again is not very, very encouraging. Real world effectiveness, of course, this was a paper, this was again an ESMO initiative wherein they saw 662 patients, out of which 381 patients had a molecular alteration, and 54% of these, that would be around 190 patients, actually received targeted therapy based upon the mutation. And particular subset of these, that is those who failed the first line androgen receptor antagonism and they had gone on to the HRAS mutated therapy, they definitely had significant progression-free survival of 19.11 months. So this was the only subset that they saw where there was encouraging results. So as of now, I would say that real world effectiveness of targeted therapy in salivary gland cancers is limited, and it's an evolving field. We need to await further trials and further literature, especially from our centers. With that, I think I would end my talk. I've not gone too much into adjuvant therapy. There is lots which is coming on proton, but I think I've already exceeded my time for 20 minutes, so I'll stop here. Thank you.
Thank you, Harsh, for that elaborate talk. So maybe for the benefit, can you discuss about the role of neoadjuvant chemotherapy in borderline resectable salivary gland malignancies, especially the
Definitely.
minor salivary gland?
Definitely. I think we have multiple retrospective cohorts wherein, based upon the patient fitness, a combination of the carboplatin, cisplatin, and docetaxel based regimens have shown some benefit, response rates close to 30 to 40% in inoperable tumors. Having said that, I think majority of these patients were mucoepidermoid carcinomas and high-grade adenoid cystics. Again, within adenoid cystic carcinomas, today we have encouraging evidence towards lenvatinib. I think lenvatinib has been promoted as one of the go-to agents for the neoadjuvant treatment as well in adenoid cystic cancers.
So thank you so much. If there are any other questions, you can please put it on the chat box and we can subsequently take it during the discussion. So there is another question. What's your take on the malignant tumors of minor salivary glands of palate and oropharynx?
So minor salivary glands of the palate and oropharynx should be treated based upon the histology, of course, and the local extent. Treatment definitely is surgery being the primary modality. And of course, the extent of surgery would depend upon the radiological extent of the disease. And again, adjuvant therapy would be based upon the common factor. So it's not very different from any other tumor of that particular site.
Thank you, Harsh. Now we will go ahead with our presentation. The case will be presented by Dr. Yamuna Ranganathan. She is a MCH resident at B. Barua Cancer Institute, Guwahati. And I would like to invite all the examiners. Dr. Harsh, you can please continue to stay as an examiner.
Yeah.
And welcome Dr. Rajiv Kumar. He's a professor of ENT and head neck surgery at All India Institute of Medical Sciences, New Delhi. Dr. Anupam Das, he's a professor in head neck surgery at B. Barua Cancer Institute, Guwahati. And Dr. Sasi Krishna.
Thank you.
And Dr. Sasi Krishna, he's an associate professor and head neck surgical oncologist at Tata Memorial Center, Vishakhapatnam. Welcome, everyone.
Thank you. Am I audible?
Yes, you're audible.
Yeah, thank you.
Thank you. Thank you, Dr. Singh.
Thank you, Dr. Singh.
Welcome, everyone. Yamuna, you can please start your presentation.
Is my screen visible, sir?
Yes, it's visible.
Yamuna,
Yes, sir.
go ahead.
Can I start? Yes, sir. My patient is a 80-year male, resident of Assam, who presented with the chief complaints of swelling below the right ear lobule for the past 7 months. History of presenting illness. On elucidating the history, patient also provides the history of surgery to the parotid on the right side on July 2024 at outside center. Patient was apparently asymptomatic post-surgery. Now we presented again with the complaints of swelling below the right ear lobule at the same site for the past 7 months duration, which was insidious in onset. It was initially a pea size to begin with and increased to the current size.
Dr. Yamuna,
Yes,
Dr.
sir.
Yamuna, what was the diagnosis, histopathological diagnosis in the last surgery?
So that was mucoepidermoid carcinoma, sir.
Okay. Was there any more information on that?
So there isn't any information about the surgery details. They are mentioned the patient has been operated and the HPR was mucoepidermoid, and even the HPR details wasn't mentioned at all. But
Okay,
the size
low grade,
of
high grade, nothing.
nothing has
What
been
about
mentioned.
low grade or high grade? Was it mentioned?
Yes, sir. Nothing. It was not mentioned.
Nothing mentioned. And the patient did not receive any adjuvant treatment or any further surgeries, right?
Also, nothing.
Okay, go ahead.
Yes.
If that is mentioned in the history, it is better. Did you mention anywhere all these points anywhere in the history?
Yeah, sir,
In
in
the
the
past?
minor, yeah.
Okay, go ahead.
History of skin ulceration over the swelling for the past 2 months. No history of sudden increase in size of the swelling. No history of pain or increase in size of swelling while eating. No history of fever or discharge in the oral cavity or halitosis. No history of dry mouth or swelling in and around the eyes. No history of pain or swelling in the contralateral side. No history of asymmetry of the face, difficulty in closing of the eyes, deviation of angle of the mouth or drooling of saliva. No issue of decrease in mouth opening, no issue of swallowing difficulty, no issue of voice change, regurgitation of the feet or difficulty in shoulder movements, no issue of swelling or ulcer over the eyes.
Yamuna, what is the importance of voice change in this patient?
Sir, in case of deep lobe, that is deep lobe of parotid involvement or parapharyngeal space involvement, there are chances of involvement of lower cranial nerves, 9, 10, 11,
Okay.
and 12. So if the 10th nerve vagus, if it is involved, there are chances of hoarseness of voice. So that's why I asked
Okay.
this.
Okay, go ahead. And
No,
what about trismus? How there can be trismus in patients of carotid tumor?
one is when there is a extension of the swelling towards the involvement of the masseter, then it can be difficult, decrease in the mouth opening. Masseter involvement.
Continue.
No history of ulcer or lesion anywhere in the oral cavity or throat. No history of ear discharge or bleed. No history of fever or swelling anywhere else in the body. No history of cough, bone pain or weight loss. And no history of radiation.
Okay.
Past history, patient is a known hypertensive and he is on medications for the same for the past 15 years. And as I mentioned earlier, there is a history of prior surgery. Final HPR was mucoepidermoid carcinoma. And personal history, mixed diet, bladder and bowel were regular, and he had a history of smoking for the past 15 years. Summarizing my clinical history, my patient is 80 years male, known hypertensive, already been operated for parotid swelling on July 2024. Presented with the complaints of swelling below the right ear lobule since 7 months, which is progressively increasing. with the history of skin ulceration over the swelling for the past 2 months. So moving on to general examination, patient is
Dr. Yamuna,
Yes, sir.
so any other negative history you would like to ask, especially in a patient who already underwent a parotid surgery?
Sir, I think so. I missed about the history of hypoesthesia or loss of sensation over the ear lobule because he has been previously operated in case of greater auricular nerve. There are chances of loss of sensation, which I have not asked.
And also face
Yes, sir.
syndrome.
Yes, sir.
Why there can be loss of sensation on the face, Yamuna?
So not on the face, over the ear lobule, sir. When the greater auricular nerve during the surgery, if the
No.
anterior branches.
Yeah. Sometimes there can be loss of sensation over the face also, as Dr. Shashi asked, or rather he commented that there can be loss of sensation on the face. What is the pathway for that? Neurological loss of sensation on the face.
Loss of sensation on the face. That is also the greater auricular nerve, loss of sensation over the angle of the mandible sensation loss will be there because of greater auricular nerve involvement.
Dr. Shashi, are you happy with that answer?
No, sir.
Hello, Dr. Yamuna. Hello.
Yes, sir. Good evening, sir.
Good evening. I just want to know, based upon your history and the information you have, what do you think the previous surgeon have done? Whether he has done enucleation or whether he has done limited surgery? What is your thought from that?
So it might be enucleation only. Because of short DFI, he had been operated in July 2024, and such a short duration patient had developed the swelling, as well as there is a skin ulceration also. So it might be the enucleation only.
Any
And
other point that support? Yes, go ahead, sir.
Was there any previous FNAC done before the last surgery?
Previous FNAC, sir, they don't have the documentation of the previous FNAC.
But on history, like we can sometimes prove that whether before the surgery there was some needle test was done or not. It's very important in the sense that whether the surgery was directly done on a mobile swelling in the parotid or whether there was some diagnostic test done before that or not. Because that changes the approach of the surgeon also. We have seen many patients in which there is no needle aspiration or cytology is done and directly the patient being operated like enucleation or something. And they have more chances of recurrences and tumor spillage also. I think you can go ahead.
So Yamuna.
Yes, sir.
So yeah, first you can summarize your history. You had summarized your history?
Yes, sir. He's a 8 years male, known hypertensive, already been operated for parotid swelling in July 2024. Presented with a swelling below the right ear lobule since 7 months, which is progressively increasing with the issue of skin ulceration for the past 2 months over the swelling.
So suppose you have no access to the histopathology of previous surgery. So based on the clinical course, can you say what points towards a malignancy, and can you comment on grade of malignancy?
So points towards the malignancy is patient is 80 years and with a short DFI July 2024, and one more is it is a short history of 7 months duration, and also the history of skin ulceration that is pointing towards the malignancy, which can be high grade also because of that.
Okay, so you should mention that when you sum it up,
Yes,
that this is most probably you are dealing with a malignancy of parotid and most probably a high grade malignancy.
yes. So shall I proceed?
Yes, go ahead with the examination.
Coming to the local examination, a 4x3 glomerulus swelling seen in the right infra-auricular lesion. The superiorly it is reaching up to the tragus, anteriorly 0.5 centimeter extending anterior to the ear lobule, inferiorly up to the angle of the mandible, and posteriorly it is obliterating the retromandibular groove. And it is a well-defined, it has a well-defined borders, and overlying skin has ulceration along with erythema also, and the ear lobule is lifted upwards and the pinna is normal, and there is no other neck swelling was noted, and there is no facial asymmetry as well. Coming to the palpation, my inspectory findings were confirmed of 4x3 single well circumscribed swelling situated in the right infraauricular region, which is firm in consistency, mobile. Skin is ulcerated of around 1 centimeter, that is seen along with the erythema. Oral cavity examination was normal, and the examination of facial nerve was also normal. There is no lower cranial nerve deficit. Oropharynx, there is no bulges noted in the tonsillar fossa. Hopkins examination, bilateral local cord was mobile. Neck examination, there is no clinically palpable lymph nodes. Eyes, ears, scalp examination was all normal. Systemic examination was also normal. I would summarize the examination, clinical and the examination findings. My patient is a 80 years male who is a known hypertensive, already been operated for parotid swelling on June 2024, presented with the swelling below the right ear lobule for 7 months duration, which is progressively increasing with the issue of skin ulceration for the past 2 months. On examination, 4x3 centimeter swelling in the right parotid region with the skin ulceration without any palpable lymphadenopathy or facial weakness. So according to AJCC, clinically it is a T4A, N0 and M0. Staging is stage 3A.
Did you do an examination of the ear?
Yes, sir. I've done the examination of the
You
ear.
have done an ear examination. Okay. Why a examination of the scalp is important?
Sir, one of the etiology for the parotid swelling is the due to metastasis from the distant site. Out of the metastatic sites, if there is a disease in the scalp, eye, ear, and all, there are chances of metastasis like cutaneous squamous cell carcinoma, melanoma, and all, basal cell carcinoma. They all metastasis to the parotid. So that's why I examined the scalp and all to look for any cutaneous lesions.
And where is that node located on the parotid? Is it a superficial node, superficial lobe, or deep lobe?
Sir, on the clinical examination, it seems to be superficial because the swelling was mobile. But there is also a retromandibular groove obliteration. There is a doubtful of deep lobe involvement as well. But it is kind of a mobile swelling.
I'd again come to that same point. Did you look for any loss of sensation of the face anywhere? 2, 3, 4, V1, 2, 3.
Okay, trigeminal nerve involvement.
Yes.
Yes, sir, there is no loss of sensation as such. Patient also didn't give any complaints of it.
Okay, and what about the neck findings? No palpable neck nodes.
Yes, no palpable neck nodes.
Okay. Yes, go ahead.
So my differential diagnosis would be the neoplasm of the parotid gland, and the patient had already done the outside investigation. So I would like to proceed with the imaging part.
Continue.
Yes, sir. CE-MRI base of the skull to the
Would you generally do a MRI first, ultrasound, or a CT scan?
Sir, generally ultrasound is the first line investigation, but in case of certain suspicious features, we directly go for the MRI. As in my case, it is a recurrent patient, so I wanted to look out the differentiation of the scar and the parotid swelling and all. And second, he has skin ulceration, which is a high grade one, so I wanted to look for the extent of the swelling as well as for the neck nodes. And one of my clinical findings is also obliteration of the retromandibular group. So I wanted to look out for the deep lobe involvement and the extent of the swelling as well. So I would generally prefer to go with the CMRI based on the neck for this patient.
Okay. In which cases do you think CT would be more helpful?
So CT is done to look for the bony involvement like temporal bone, mandible. So to look for the bony erosion, CT is helpful, sir.
Okay, good. Can you
just a question? Sorry. Please go
no,
ahead.
it's okay.
Good
Yes,
evening.
sir. Go ahead.
I just wanted to ask, on MRI, what would be your red flags to suggest that what you're dealing with is probably a malignancy? Are there any clinical signs on MRI, radiological features?
Radiological features, sir, T1 and T2. It is always the T2, which if it is a low intensity, that is goes towards the malignancy, and also the infiltration of the adjacent structures like masseter, irregular margin, irregular borders, and also the facial nerve like a perineural invasion that also points towards the malignancy.
And also contrast enhancement. That is again, it is
Contrast enhancement,
yeah.
yes.
But more than contrast enhancement is always, as you said, a hypo intensity. But it's not just T2. I think it's T1 also. Just read it about. Just read
Yes,
about
sir.
it. And one more thing that you must mention is, or what you should know is, if suppose you have a mass which is hyper intense, both on T1 and T2, you don't have an FNAC, but it's hyper intense on T1 and T2. What would be your first differential?
So my first differential would be the benign etiology because
Specifically,
specific
Specifically, it will be pleomorphic adenoma.
pleomorphic
That's a very classical feature on MRI for a pleomorphic. It is hyperintense on T1 and T2.
yes.
Oh, go ahead. Anupam, sir, please.
Yeah, Yamuna, continuing with Dr. Harsh's question, what will be like the features of a facial nerve infiltration based on MRI
Based of
or facial nerve involvement? Yeah, go ahead.
So based on MRI, there will be the enhancement of the nerve along the course of the nerve. There will be enhancement.
What else?
The-
Enhancement beyond that, anything else? Any other findings?
And widening of the foramen, that will be more seen in the CT scan actually.
Hmm.
And erosion of the bony margins around the facial nerve.
Erosion is I would say it's an advanced finding. Without that, there can be thickening of the nerve.
Thickening of the
Okay,
nerve
there can be thickening of the nerve, enhancement, fusiform appearance of the nerve. Then in the foramen, there can be loss of fat.
loss of fat.
In the stylomastoid foramen, there can be loss of fat. So there will be findings based on the with that will predict towards the facial nerve involvement. Another thing, yes, go ahead.
So Yamuna, any particular sequence of MRI you would like to look for perineural spread?
So T1 post contrast and the fiesta sequences would be specific for perineural.
Yeah, T1 post contrast, fat suppression images.
Fat suppression images.
Yes.
Okay,
Good, go
so
ahead.
These days, actually, Dr. Yamuna, whenever we have to advise the MR for this malignancies, we have to write multi-parametric MR in which we have to do ADC and diffusion coefficient also.
Diffusion efficiency.
So it has to be T1, T2 with multi-parametric sequences because you want to see nerve, you want to see extent of the tumor, you want to see the diffusion coefficient ADC map also. So multi-parametric is the term which is normally radiologists these days they say we should do for malignancies.
Yes.
So did you mention, did this patient have the classical Blair incision? Did you mention that on the examination?
Sir, I mentioned, so there isn't any, the previous incision or scar was noted. Only the skin ulceration, it seems like a normal, like a first presentation swelling one, sir. There isn't any scar was noted.
Okay. So what about PET scan in this patient?
Sir, ideally
Any
PET,
thought?
sir, ideally PET scan to be done because it is a kind of aggressive, if a patient, it's been operated early, so with that short DFI, I wanted to rule out the distant metastasis as well. So ideally PET is required in this case, sir. High grade, locally advanced also.
Yeah, can be considered.
Yes,
Go
sir.
ahead with the MRI report, with the MRI images. Yeah.
Sir, this is the axle. Sir, I don't have the proper sequence also of the this one because they have done it from outside. I have the sequences of the images only. So this is a T2 axle cut. So this is the right lobe of the carotid where it seems like a kind of a heterogeneous intensity, and there is also calcification. which is involving only the superficial lobe, and this is the part of the superficial lobe, and the masseter seems to be free from the disease involvement. And this is the stylomastoid region, and this part is the nerve. The swelling seems to be adherent to the kind of, it is not, it is like close towards the swelling, retromandibular vein also.
Okay.
These are the other images as well.
Can you
So,
show the retromandibular
This would have
vein?
been
yes, sir.
Can you show the retromandibular vein?
Sir, this one. This is the retromandibular. This part is the retromandibular vein. So in this previous cut, this would be the stylomastoid, posterior of digastric. So this is mandible. Behind the retromandibular, this part would be the retromandibular vein region. I didn't have the proper. So should I show in the normal side?
Yeah, please.
So this is the mandible masseter. So this is the retromandibular.
What is this plane? What is the plane of the retromandibular vein called? Any idea?
So it is actually medial to the nerve.
Yeah, it is medial to the nerve. There is a name to that plane.
Venous plane.
Yeah. Of?
Pate. Venous plane.
Nice. Good.
Sometimes you get a dumbbell-shaped tumor, salivary gland dumbbell-shaped tumor.
In case of.
What structure creates that dumbbell?
So it is because of the stylomandibular tunnel. The disease has to transgress through that narrow structure, so it forms a dumbbell shape.
Well,
Can you show the internal maxillary, internal carotid artery on the scan?
So this one. This is the internal carotid.
Okay, go ahead.
Sir, patient had done the FNAC outside. That was suggestive of mucoepidermoid carcinoma, and they have not given any Milan's grading also for this. Just a feature suggestive of mucoepidermoid was mentioned.
Okay, talking about Milan's grading, how many grades are there in Milan's?
So Milan's, it is 6 grades are there. One is non-diagnostic, non-neoplastic, 8 type of undetermined significance, 4A is benign, 4B is salivary of uncertain malignant potential, 5 is suspicious of malignancy, 6 is malignancy, and each grade, each category grade is as a risk of malignancy also. Based on the risk of the malignancy, further plan of management to be considered. For example, in case of 1 and 3, we have to go for FNAC since it is non-diagnostic and 8 IPR. If it is grade 2, can go for follow-up. So based on the risk of malignancy also it changes.
Okay, go ahead. So would you consider doing a true cut biopsy in this patient? Do you feel there's a need to go for a true cut tissue biopsy for this patient?
Sir, not so. FNAC would suffice.
Suffice. In what cases do you think a true cut biopsy will help?
Sir, in case if the FNAC is non-diagnostic, if there is a suspicion of lymphoma, and because we wanted the immunohistochemical IHC markers has to be there for subtyping, as well as if there is a plan for any targeted therapy, so in that case also core biopsy is helpful.
Okay, so you have a diagnosis of a mucoepidermal carcinoma. Now, what do you want to do more with this patient?
Sir, I wanted to rule out the distant metastasis as well. Since I have done the MRA and the neck, I had to go for the distant metastasis, so I will go with the CECT thorax.
What about PET scan?
Why CECT? I think METs can be seen on NCCT or HRCT chest also. Why you want to add contrast to the chest?
Sir, in case of the metastasis, the uptake would be better, as well as since the nodules are more towards the to look for the proper metastasis, CECT would be the better option, sir. The sensitivity is more with the contrast.
I think it is non-contrast CT chest which is normally done for all metastatic workup. You can recheck, but as far as all guideline, it says NCCT chest tone
Okay, sir.
or HRCT
Mhm.
chest tone.
Okay, sir.
Mhm.
Yeah, NCCT chest should suffice. You don't need contrast
Okay, sir.
to look for lung metastasis.
Mhm. Okay, so you have done the metastatic workup. You have a FNEC diagnosis of mucoepidermoid carcinoma.
Yes.
Now, how would you like to go with management of this patient?
Sir, I would.
So, Dr. Yamuna, one more thing, because this is a outside FNSC, would you review in your institute first?
Yes, sir. We would like to review this at our
So
sites. So,
have you done it?
sir, we have
No.
submitted the slides, sir, but reports are still pending.
So by clinical history and examination, it looks like high grade, but would you like to know the grade before the surgery, final surgery?
Sir, grading.
Will it change something for you?
Sir, it doesn't change the management for this patient. As such, FNEC, they generally don't go with the grading also, like high grade or low grade. But even if it is, it doesn't change the management of for the patient because according to clinically, already there is a skin ulceration. So I would go with the removal of like both the superficial and the deep lobe as well. So it is not going to change management for this patient.
What about the prognostication for the patient?
Yes, sir.
Low grade mucopurulent versus high grade mucopurulent
High grade
carcinoma.
has a bit poor prognosis compared to the low grade tumor. Yes, sir. It changes the prognosis.
So it help in counseling the patient and attendants that your disease is aggressive disease, and it help you might be requiring further adjuvant therapies when the final histopath report come. So prognostication is also very important apart from just doing surgery. It helps the patient and the relative to understand the natural course of the disease, and they
Counseling of the
counseling, and they assume that they are they have a aggressive disease.
Even for the facial nerve thing also, Yamuna, high grade. If you know if it's a high grade, it's sometimes easier to decide. I mean, I completely agree that for a functional nerve, we'll always try to preserve the nerve as far as possible. But for a high grade tumor, if it is very firmly adherent, maybe we may sacrifice smaller branches if it is for that part. So that is again an important thing to know before going ahead with surgery, whether you are dealing with a low risk tumor or a low grade or a high grade tumor. That is important to know. Okay. So what's the plan for surgery for this patient?
Sir, before proceeding with the surgery, I would counsel I would like to go with the routine blood investigation for the pre-anesthetic checkup, and then I would counsel the patient that what is the disease status and what is the aggressiveness of the disease, and about the surgical aspect, what surgery what surgery will be planned, and what can be anticipated during the surgery. For example, facial nerve or not, and the patient definitely is going to be receive the adjuvant therapy that also will be counseled accordingly, and then I'll proceed with the this would be the total parotidectomy along with the skin excision, and since facial nerve is normal, regarding the facial nerve, that will be decided based on my intraoperative finding, but still the patient will be counseled earlier about the facial palsy post-op based on the intraoperative findings. It will
So
change.
total conservative parotidectomy will be the plan, right? For the face with an intact facial nerve, at least.
Excision. Yes, so skin excision would be there.
So, Dr. Yamuna, would you like to offer any adjuncts to the patient during surgery?
Yes, sir. Because since it is a recurrence case, I'm not sure about the previous surgery as well. So it would be better if I go with the intraoperative nerve monitoring during the surgery, so that the preservation of the nerve to prevent the
Dr. Dr. Yamuna, what will be your extent of neck dissection for this patient?
Sir, this would be 1 to 5 will be my extent of neck dissection. Since this is the high grade, so I would go with that.
So is the high grade is the criteria for extent of neck dissection?
Sorry, sir. It is 2 to 4. Clinically, N plus only I'll go for. It is 1 to 5.
5 years.
2 to 4.
Because this is a N0
N0 next.
N0 patient. Yeah.
So you will do 2 to 4.
Yes, sir.
So Dr. Harsh, in his presentation, told that when the tumor is posteriorly located, you have to also address the level
Level 5 as well.
5A. Because we have seen in our data and our prospective study that up to 22% of the patient had 5A lymph node positivity. So in the anterior based tumors, 1A need to be 1B need to be addressed, and in posteriorly based tumor like your mandibular groove is obliterated. So I think 5A
Would be
should
the
be sampled at least.
yes.
Yamuna, have you gone through the European Association classification of salivary gland surgeries?
Yes, sir. I've gone through that EGS classification.
Okay.
By Queradol, I have seen.
Okay. Okay. So for you, which is the most consistent way of identifying the facial nerve?
So there were around 4 landmarks are there. One is a
Mhm.
tragal pointer, posterior belly of the digastric, tympanomastoid suture, and styloid process. Styloid process we don't use because it is always nerve is always medial to it. But the most ideal and reliable would be the tragal pointer and the posterior belly of the digastric. Because at the level of posterior belly, it is at the same level, facial nerve is at the same level, and it is around 3 millimeters superior, 3 to 5 millimeter. And tragal pointed is nothing but the medial most part of the cartilage of the EAC, that is a extension medial part of the extension, pointed extension. Around 1 centimeter deep and inferior to it is the facial nerve. So these two would be my reliable landmarks during surgery for identification of facial nerve.
What about frozen sections during surgery, Yamuna?
Sir, frozen section. The role of frozen section during during the parotid surgeries are for the lymph node sampling, and for the facial nerve, it is if there is a plane, I would always like to preserve the nerve. But if there isn't any plane, if it is so difficult, and if I am preserving, if there is R0 resection at all the levels, only this is the part which is very doubtful for me. Then in that case, I would take the perineurium for the frozen section. If it is involved, I'll go for sacrifice. And even then, I wanted to rule out the extension of the perineural. So for that, the margin of the perineural invasion, so that I needed a frozen. So these two indications are the key for the intraoperative.
Yeah, also for like if there's an advanced tumor, then for even for margins, you may do a frozen section. So for an advanced tumor involving the skull base, then for the margins also you might look into the frozen section of parotid gland of the parotid surgery.
So how would you reconstruct the skin defect? And how much margin you will take around that ulcer?
Sir, I would take around 1 to 1.5 centimeter margin around the skin.
So
1 centimeter margin at least I would take around the skin, sir.
okay, and how will you reconstruct?
Reconstruction, since I'm not going with the 1A, so submental flap would be the option. And around the already the growth ulceration is around 1.5 centimeter. If I take 1.5 as well, it would be around 3 centimeter. And there is a erythema also, so it would be around 4 centimeters. So in that case, PMMC it's an overkill. But still, apart from this local flap of submental, and then there is a supraclavicular flap supraclavicular islanded flap is also an option. But still, since I would be going for level 4 and level 5, if I am preserving the transverse cervical in case of injury, in that case, that would be very difficult for me. Or else, if these two options, if it is okay, and even then I have the option of the PMMC, and it is something kind of overkill. And also free flap options are there. So free radial artery forearm flap.
So Dr. Yamuna, so PMMC, in this case, we need bulk. So musculocutaneous flap is not a bad idea in this case, because if we do a fasciocutaneous flap, this patient will also receive radiation. So he'll be ending up with a very hollow defect. So overcorrecting with a musculocutaneous flap is not a bad idea in this case. So we should be looking at musculocutaneous flaps rather than fasciocutaneous flaps in this case.
Okay. So in case suppose Yamuna, you have injured the facial nerve or you had to resect the facial nerve. So what are the options that you have?
So for reconstruction of the facial nerve,
Mm-hmm.
if the distance is like around less than 1 centimeter, I would go for the primary repair, like epineurium to epineurium. I do the suturing using 90-ethanol. If the distance is more than 1 centimeter, if I have a proximal as well as the distal stump of this, so I would go for the interposition graft. Interposition graft, the nearly available is the hypoglossal, and as well as there are options of greater auricular nerve, and then there is option of sural nerve as well. It is based on the proximal
So
and the distal.
between hypoglossal, greater auricular, and sural, which one will you select?
I would go with the greater auricular nerve.
Yes. Hypoglossal, I think it's not justified because by
Muscle
doing a
nerve.
hypoglossal, you'll be going to a, yeah, you'll be denervating one half of the tongue. So a greater auricular nerve is a better option. To tell me two very important points before going for the, I mean, definitely you'll be going for a nerve graft, but two very important points that you may need to make sure before going for the nerve repair. Rather, one point I would say.
So one point is with the frozen I want to rule out the negative margin.
Yes,
That is the
it's
most
very important that you rule out that the nerve that you have left is completely negative. So a frozen section is very important for that point. So that becomes a nerve graft. Do you have any other options like muscle transfers?
So there are static approaches, static procedures, and dynamic procedures.
Mm-hmm.
This muscle transfer comes under the dynamic procedure, and there is also option of the cross facial nerve graft is there, wherein opposite side nerve. From there we take the from there it is the facial nerve, and then there will be the interposition graft, and then this will
Cross facial, I think it's not, we wouldn't
be
consider a cross facial for this kind of patients.
yes.
For this kind of patients, what would you prefer? Other than the, I mean, let's talk about the muscle transfer. What are the tendon transfers you can do?
So temporal is tendon transfer, and
Mm-hmm.
facial atta transfer also. Facial atta also can be used for the static sling
Mm-hmm.
procedures and all.
Mm-hmm.
To muscle transfer, gracilis would be the option.
What about masseter?
Yes, masseter is also an option.
Sometimes even digastric is also given in the literature. That
Yes,
is mostly for the angle of the mouth. Then you can use a
yeah.
innervated digastric also can be used, antrobody of digastric.
But sir, I just want to add one thing here. But all these tendon transfer, they are mainly described for chronic facial nerve palsy when there is not a option of dynamic facial reinnervation. So in the current scenario, the best will be the interposition graft either with sural or greater auricular nerve. Like temporalis tendon transfer or other muscle transfer, they are mainly described when the duration of facial nerve palsy is more than 18 to 24 months and there is no chance of dynamic innervation. Then we can do that kind of procedures. But here, if you do a nice interposition graft with either sural or greater auricular, and you can do temporary upper lid loading also with either gold weight or platinum chain till the nerve take its effect, which take around 6 months to 12 months to come back the function. So that can be done.
How much improvement do you think the patient will have after a cable graft
Sir,
in the function?
function it would be HB House Brakeman grading case also. It would be like 3 or 4. So mostly it would be 3. That would be
So that is very important for the patient to understand that you should, even during counseling, that is something you should explain to the patient that even if you go, it's not going to be a full recovery. What about adjuvant treatment for this patient?
So this patient will go for the adjuvant radiation since it is a locally advanced eye stage disease. So you will definitely go for adjuvant therapy in the form of radiation.
Which group of patients generally you would advise adjuvant treatment
Sir,
as
T3,
a general?
sir, T3, T4 eye stage, eye grade, perineural invasion, lymphovascular invasion, N plus nodal status, pathologically nodal positive patients. So they all go for adjuvant radiation.
Now, suppose you have done facial nerve repair for this patient and you go for adjuvant treatment. So, what does the literature say? Like, does radiation adversely affect
Yes, so that is
the
not.
facial function?
So that is not going to affect the outcome of the facial nerve reconstruction. So radiation is
Sorry,
not the outcome.
sorry, say that again. I didn't get you.
Sir, facial nerve reconstruction, if a radiation is given, that is not going to affect the outcome of facial nerve reconstruction. Can be radiated. There isn't any.
Okay. Mm-hmm. Okay. Good. You have given a good this thing. Role of any adjuvant chemotherapy for this group of patient, like other squamous cell carcinoma, where we would go with adjuvant RTCT. Is there a role of chemotherapy for this group of patient?
Sir,
Advanced parotid tumor.
so there isn't any proven literature as of now. There is the study RTOG 1008, the prospective study. The results are still pending. But as such, the ASCO guidelines, it has mentioned there is no data which has proved. Even there were 2 or 3 previous data like Amini et al. They have given CTRT versus the radiation. But even then, the outcome was not good, even adding the chemo to the radiation. So there isn't any proven data. We would be waiting for RTOG 008, 1008. That might make some sense.
Okay. So should this patient recur the third time? Should this patient recur the third time? What are your options?
So if this patient recurs for the third time, considering his age, and it is a kind of aggressive disease only. So I have to look out for the distant metastasis and those morbidity to be considered. So re-radiation also, surgical morbidity will be there, and re-radiation also wouldn't be any option if the recurrence is like within 1 or 2 years duration. So I would like to keep him on. If it is a recurrent, it is better to keep him on chemo. And even considering 80 years, chemo wouldn't be an option also.
Is there any other non-conventional form of radiation that can be given?
So you mean to say that neutron therapy and all?
Yeah, particle beam therapy.
Yes, a particle beam therapy. There are 2 trials which I've read. One is the cosmic and one is the neutron versus the photon, which had around 12 and 15 patients. In that, it is mentioned local control was better when you give the neutron therapy, but the patients were not, the overall survival was not good because although patients are going with the distant metastasis. And as such, according to ASCO guidelines, there isn't any proven data for going with the particle therapy. There isn't any prospective trial which has proven comparing the Indian IMRT versus the proton therapy. There isn't any data which has been proven.
That is true. But you have single arm cohort studies where inoperable salivary gland cancers with proton therapy have shown a decent progression-free survival at 3 years of about in the tune of 65 to 75% also. So it may not be completely curative, but definitely you can prolong the survival. That is, there is a meaningful PFS and also improvement in the quality of life.
Dr. Hirsch has already touched upon certain markers and certain therapies. So just can you repeat them? What markers you may consider?
Yes, sir.
Which mutations you can which mutations you may consider, and if possible, go ahead with some sort of
Yes, sir. Targeted therapy, sir.
treatment. Yeah.
Sir, targeted therapy, salivary gland carcinoma, we have the androgen receptor adenine, which is similar to the breast intraductal carcinoma. So,
Mm-hmm.
androgen deprivation therapy, bicatulamide, leuprolide, enzalutamide, there is a role of it. And coming to the adenoid cystic carcinoma, there are TKAs, lenvatinib, sorafenib, sunitinib, they are being used. And coming to secretory carcinoma, ETV6 NTRK3, that is 12 and 15 chromosome, there is a role of larotrectinib and entrectinib in those cases. And if there is a tumor mutational burden is high, I can go for the cytotoxic chemotherapy as pembro, ipilimumab, and nivolumab.
Mm-hmm.
But that was mentioned in the guidelines, but there isn't any data which is proven. So in case of tumor mutational burden, if it is high, and there is also a cytotoxic chemotherapy if the patient is so symptomatic. So that is also there. Platinum-based components and adenocarcinoma not otherwise specified in that it is pertuzumab with a combination of paclitaxel. Sir has already mentioned the progression-free survival of matlab it is around 18 months and the response of 60 months, 60%. So these are some of the systematic therapies.
And please don't forget lenvatinib for adenoid cystic.
Yes.
Mm.
Okay, please don't forget lenvatinib.
Yes. Yes, Dr. Shashi, you go ahead
Yeah.
if you have any more questions.
Dr. Jabana, any idea about basket trial? Did you listen to this
Basket
term?
trial,
Basket
it
trial.
is, yes, sir. For the radiation part, it is a NCDB database. I'm not sure about the year. I guess it is 2011 or 2013. But they have stratified the patients into low risk, intermediate, and high risk. Around 8,000 patients were there, 8230 some patients. High risk is all they have taken extra capsular extension and the nodal N plus as well as the positive margins. Intermediate risk is like this one, LBI, TNI, T3, T4 and all. Low grade is rest of all the patients were in the low grade. And when they were given RT, they found that the group in the high risk, they had a better survival. That is around 68 and 60% or something around that. But in this database, they have seen like around 10% of the patients were receiving chemotherapy as well, but that is not added any benefit to it. They found only the radiation part, that is the patients were doing better. Those patients who are high risk, N plus and the positive margins. So that is the basket trial.
Sorry, I'm not aware of this basket trial. So generally basket trials stand for very rare malignancies where you can't do a trial for such cases because they're very rare. We can't reach a sample size to do a trial. So they generally pull up such very rare malignancies and they, if they have a common mutation, they test a particular drug, whether it works, irrespective of the histology. They look at common mutations.
Sorry, sir, I
So
was thinking that the radiation basket trial is there, so I thought you were asking that.
you can go and look at some basket trials on salivary gland tumors because they have many targetable mutations. There are some trials on this. So you talked about the best possible outcome after nerve coaptation. So how fast will be the recovery? When do you expect the facial muscles to function, to regain this function?
Sir, it would be around 6 to 9 months.
Okay. So what will be the nerve regrowth after coaptation?
So 1 millimeter, sir, the duration, the size you are asking, like the distance, so it is around
Yeah.
1 millimeter kind of per day.
Yeah.
1 millimeter per day that we used to look for the Tinel sign. So that is 1 millimeter per day, sir. I don't know as far as I remember.
So immediately there will be 1 millimeter growth immediately after coaptation.
Sir, it wouldn't be immediately. It will be around later, more than 3 weeks, around 1 month ke baad only we can do it, because of the epineural layer that has to be formed, and later then only the filaments, neuronal filaments, and then there is a syncytium will be happening. So it will be around 3 weeks later. There will be growth around 1 millimeter per day.
Yeah, roughly after 2 months.
So, Dr. Yamuna, when you do nerve grafting, what sutures you prefer?
Sir, 90 epsilon.
90. And how many sutures you prefer for interposition graft?
Sir, around 4 sutures.
4 sutures.
4 suture like matlab, yeah, only 4, around 12, 6, 3, 9 o'clock position, only 4 suture.
Okay. And do you think these sutures, the number of suture impact the outcomes? Because there is one question that this suture might interfere with the neuroaxonal
Regrowth.
this regrowth.
Yes, sir.
Because there are many studies which says even 2 sutures are adequate, and in temporal bone they don't even suture, they put only glue and cover it with the fascia.
Yes, sir.
So the number of sutures are not does not matter. The approximation is very important, and whenever we suture, we take a fascia and we cover with the fascia and put a bit of glue around that 2 or 3 suture, whatever we have taken, to stabilize the coaptation.
Yes, sir.
So that is very important. So what is the optimal outcome for your patient after adequate surgery and postoperative radiotherapy? What is the 2-year, 5-year survival for your patient? How will you explain to your the patient and attendants? Because he's already 80 years.
Sir, mucoepidermoid carcinoma, considering this has to be the high grade. So based on the staging, it is a stage 3. So stage 3 is around 40, around between 40 to 30% only the survival rate. Stage 3 and stage 4.
Overall survival.
Yes, around 40%.
And disease-free survival?
So disease-free survival, I don't remember, but overall survival is around 40%. There is a study by Rajesh Shekran et al. Wherein he had given the mucoepidermoid carcinoma about the clinical pathological details and all, and he had looked for the outcome in which the female have a good outcome, but the male patient grade, so it had a survival of around, if it is the stage 3 and 4, it is around 40%.
Is age the prognostic factor for this patient?
Sir, sir, in that study, it has mentioned the age is also one of the factor.
Because this is the most common salivary gland malignancy in kids also and in adults also. So is age a prognostic factor or not?
So it is one of the prognostic factor.
It's a poor prognostic factor for this patient.
Sir, I'm not sure, but mucoepidermoid carcinoma high grade, that is also one of the prognostic factor.
Yeah, high grade is a poor prognostic factor, but for your patient, 80 year is I think is a poor prognostic factor, but you can cross check.
Yes, sir.
I think very nicely presented, and Dr. Asim, I think we can conclude also now.
Yeah, we can conclude. Can give your final comments and then we can conclude.
So I would say Dr. Yamuna has done exceptionally well. She has answered most of the questions and with the evidence-based answers. So excellent presentation and excellent.
Thank you, sir.
It's very
Yes,
nice.
Yamuna, I'm happy with you. You have done a good presentation, actually.
Yes, sir.
Almost you have answered everything. The only thing you were confused, I was asking
Why
pathway for loss of sensation. That's usually through the auriculotemporal nerve that is involved, and then from that it can migrate. But otherwise, that's just a kind of question, just trick question I asked. But then you have done really well. Proud of you.
Yeah, she had done well and she's thorough with the evidence also.
Mhm.
All the best for your exam.
Thank you so much.
Thank you.
Thank you, sir.
So thank you, everyone. Thank you, Dr. Harsh, for the excellent lecture. And thank you, Dr. Anupam, Dr. Rajiv, and Dr. Shashi. And thanks, Yamuna, for the presentation. We shall meet once again after 2 weeks.
Thank you.
Thank you.